Welcome everyone to the final mini lecture of this series looking at overweight and obesity in adults. Today we're going to concentrate on a case study looking at a woman who's been diagnosed with PCOS, which is an acronym that stands for polycystic ovary syndrome. As you know, my name's Dr. Kathy Knight-Agarwal, and I'd like to thank Dr. Jani for the opportunity to share my expertise in this area of very important clinical dietetic practice. So, you're a dietitian working for the fertility service at Royal Brisbane and Women's Hospital. The team also includes a gynaecologist, a psychologist, midwives and social workers. You, the dietitian, have received a referral from the gynaecologist to see a 28-year-old woman, Amipa, for weight management advice following her diagnosis with polycystic ovary syndrome, including insulin resistance and an impaired fasting glucose reading. She originally presented to the gynecology clinic for evaluation of infrequent menses since menarche. The patient stated that on average she has one period every 6 months. When she does have her period, she bleeds very heavily, passing large clots, and has a lot of cramping. She also complained about excessive facial hair, which requires her to shave at least once every several days, and a lot of hair on her abdomen and arms. Amipa stated that her mother also has a lot of facial hair, but doesn't think that she does anything about it. Amipa is married to Alapate, and are both of Tongan heritage but Australian citizens. They are devout Christians. Amipa works full-time as a receptionist for a local building firm in Brisbane. Amipa denied any change in her voice or increase in the size of her muscles. She has been obese since she was a very young teenager. She has never had any surgery and has never conceived, despite several years of trying. In recent history, Amipa has not been taking any medication and has never used any form of chemical contraception, for example, something like the pill. The clinical features and test results that you will see shortly and will review are consistent with polycystic ovary syndrome. Because Amipa desires a pregnancy, the obstetric and gynecology registrar recommends that she start metformin for control of her blood glucose, and he also commenced her on clomiphene to induce ovulation. Amipa has been successfully losing weight after she was encouraged to do so by her GP. In the last 10 months, she has lost 30 kilograms. The gynecology and obstetric registrar has referred Amipa to you, the dietitian, for nutritional assessment and dietary advice. As you're all aware, and we also reviewed in one of the previous lectures, this is where you start to complete your information gathering. So in the first instance, you're going to undertake your assessment. So as we previously discussed, assessment is made up of a number of very important categories, and we categorize our nutritional assessment using the A, B, C, D and E. So this is assessment made easy. As you know, A stands for anthropometry, and in this instance, you need to take all the available information from the referral that the Gynecology and Obstetric Registrar has provided, and also obviously undertake your own calculations in relation to what is relevant, what are relevant parameters that are going to help to support this patient with weight loss. We know that her current weight is 98 kilograms and that she has undertaken a significant and recent amount of weight loss on her own, which is to be very much congratulated. When we work out her BMI, she is in class 1 obesity and her waist circumference is 92. So these values are still indicative of an increased risk of chronic disease, and also undoubtedly are contributing to her inability to conceive. As you can see here, once again, B stands for biochemistry. And so what are the relevant values that are going to help you provide the very best evidence-based advice for this patient? Well, her HDL cholesterol is lower than it should be, and her fasting blood glucose level indicates that she has impaired glucose tolerance. Her fasting insulin is very high, and her various hormone levels are indicative of polycystic ovary syndrome, in addition to having high levels of androgens, which are one of the reasons why when we look at her clinical parameters, she's experiencing things like acne, etc. Also of note is that her vitamin D is on the lower end of normal, and it's getting to the point where it may end up giving her leading to rather a deficiency, which is something to be mindful of, particularly as she is wanting a pregnancy. So here, C, of course, is clinical. And so we note from the referral and the information that we have available to us that the patient has been experiencing very heavy periods. She is a member of the Christian faith, which may be important because understanding someone's religious beliefs and cultural background is certainly going to help you provide the very best individualised care, because we know that food and beverages and when they're eaten and how they're eaten are inextricably linked to many of the world's great religions. She's married and she desires a pregnancy, but she has a zero gravida, which basically means she has not experienced a pregnancy previously. We know that she's from a South Pacific Island background, and she's been experiencing acne and hirsutism, which are very much characteristic of having high levels of androgens. She works in a sedentary job and undertakes fairly low levels of physical activity. Her bowel habits are normal, and it's reported that she has no known allergies or intolerances. She's currently just been commenced on metformin and clomiphene, and she is taking a multivitamin. So D, of course, stands for diet. And with the limited amount of information that we have, we are able to see, though, that she is eating regular meals. However, she's not meeting fruit or dairy serves. There is a relatively high intake of discretionary foods. The carbohydrate foods that she's consuming tend to be high glycemic index, and she doesn't drink alcohol. So our final category under the assessment banner is E, and of course that stands for energy. We've estimated that her actual energy intake is around 2,900 kilocalories a day. If we, using Mifflin's equation, which is, as you know, recommended energy calculation for people with a BMI of 30 and over, that her recommended daily intake is for around 2,395 kilocalories. So essentially what we want is to help facilitate further weight loss with this patient, and so therefore a further decrease in energy intake is required. So in order for that to happen, we need to take off around about another 500 kilocalories a day if she is, or if we're going to help promote a weight loss of around 500 grams a week. So 500 to 1,000 grams a week is considered to be a safe and sustainable level of weight loss. So now that we've undertaken our assessment and we are now able to write a PES statement, which of course is a universal language for dietitians. So this is your patient's nutritional diagnosis. So of course PES, the problem, the etiology, and the signs and the symptoms. And in the case of amoeba, the problem is ultimately, from a dietetic perspective, excessive energy intake. And it's related to food and nutrition related knowledge deficits, as evidenced by the diet history, an energy intake that's around 500 kilocalories a day over the estimated energy requirement. There's an increase or a substantial level of discretionary food intake. She has a BMI rounded to 34. Her waist circumference is elevated, and she has indicators of the metabolic syndrome, which then of course is related to PCOS, which in turn can lead and is resulting in some dyslipidemia, prehypertension, and impaired glucose tolerance. So next is our important intervention. What are you going to do as the dietitian to help facilitate, in a very compassionate but evidence-based way, further weight loss? Because we know that even an additional 5% of weight loss may actually, now that she's on ovulation induction therapy and taking the metformin, she in fact with further weight loss may be able to fall pregnant naturally. So how, coming back to the diet, how do we facilitate further weight loss? Well, you're all becoming the experts in this now, and so here is just a snapshot of some of the strategies that you can suggest, looking at her existing diet history, so things that she can swap out for other things to lower the total energy intake by, as we estimated, by around 500 kilocalories, which is required. Now that we've suggested that she makes those certain changes that I had up on the previous slide in order to achieve that 500 kilocalorie deficit a day, you might also encourage her to keep a food diary so that she is aware of the type and amount of food that she's consuming, in addition to the timing food is consumed, and where the food is eaten and why. For example, in Tongan culture, it's really very common for example, on a Sunday, which is a very holy day, to really not eat much in breakfast time, and then to have a huge feast at lunchtime or in the afternoon. And so it's information like that might be very useful if AMIPA is able to record what she eats, for example, on a Sunday, and particularly the carbohydrate foods that are, of course, the ones that are going to directly influence her blood glucose level control. Even though she doesn't have diabetes, she does have impaired glucose tolerance. And the amount and type and distribution of carbohydrate is really very important. Also, it might be wise to get a sense of AMIPA's state of mind and mood when she's eating certain foods, when she's keeping the diary, and who the food was eaten with. I just wanted to re-clarify, because we did look at this slide in a previous lecture, the importance of an individual's readiness to change when assessing whether or not they are motivated to undertake the dietary recommendations that you as the dietitian are going to provide. Because AMIPA desires a pregnancy, I have no doubt that she is highly motivated, but even still, this is something that you want to be mindful of. Also, remember, when you're providing your patient with dietary advice, it's important to gauge an individual's ability to take that advice on and to pitch the advice at a level that is comfortable for the patient. Obviously, simplifying messages and using things like plate models is going to be really important. As AMIPA is Tongan, it's really important to remember or to think about culturally appropriate ways to disseminate food information. And I know from my own experiences working in Tonga that, for example, a portion of carbohydrate is the size of an individual's fist. So this is something that you might take away from this lecture and think about more. And that if you have a client from a culturally or a linguistically diverse background, it's important to read up on information that is going to help facilitate not only a supportive educational experience, but one that is going to be truly meaningful to your patient. And of course, we end with monitoring and evaluation. So the last two categories of a DIME. It's also very useful to think about using the A, B, C and D here to ensure that you encompass all the important aspects that you want to continually monitor and that are so important to help the patient meet rather their end goal. So A, of course, weighing the patient, calculating their BMI, and perhaps also undertaking a waist circumference measure may be appropriate. And of course, doing these anthropometric assessments if the patient is comfortable and has provided their consent. It's important to check bloods, particularly lipids, blood glucose levels, vitamin D, discussing with the gynecology and obstetric registrar about perhaps Amepa commencing a vitamin D supplement, especially as she's desiring a pregnancy. And on that note, it would be, I think, very prudent to also suggest that she start taking folic acid. Now remember, the doctor has commenced her on clomiphene, which is a drug to help induce ovulation. And so she's desiring a pregnancy. So we don't know at what stage she'll get pregnant or if she will get pregnant, but this could happen unexpectedly and spontaneously. And so because of this, it's really important that not only are we encouraging the right mix of macronutrients in the diet, but obviously the right micronutrients and the ones that will ready or prepare her body for pregnancy. So obvious clinical parameters that are important are things like BP, but fatigue and lethargy, because if these improve, then Amepa is more likely to be motivated to undertake physical activity, which will help further in her weight loss journey, but also with insulin sensitivity. And of course, in terms of dietary advice that you've given her previously, it's important that you're able to monitor adherence to any recommendations and make appropriate changes as you go along. Also looking at barriers and facilitators to the dietary intervention is very important. There may be a need for referral on to other allied health services for Amepa, and so this is something to be mindful of, and of course always be guided by evidence-based recommendations, such as I've placed here on the slide from the NHMRC 2013 Clinical Practice Guidelines for the Management of Overweight and Obesity in Adults, Adolescents and Children in Australia. And they outline for active weight management in adults that fortnightly reviews for the first 3 months, and then plans for continuation of monitoring for at least 12 months is the gold standard. So this is something that you'll need to discuss with your patient and negotiate as needed.